This lecture will be briefly talked about COVID-19 treatment and respiratory ECMO from a clinical engineer's perspective. Respiratory ECMO treatment began to spread in Japan around the time of the H1N1 influenza pandemic in 2009, while the number of facilities capable of implementing ECMO is limited. It is an extremely important device within the respiratory care strategy as it can rescue even critically ill patients. Recently, in Japan, ECMO as a medical device used for treating severe COVID-19 patients has been extensively covered in the media. Gaining significant recognition as a well-known treatment, there is no doubt that it holds a crucial position in the treatment of COVID-19 and is considered highly important. The perception that ECMO is a guaranteed solution or a last resort is incorrect. ECMO is a last-ditch treatment that somehow manages to get patient through the most severe cases of the disease. Moreover, regardless of allocating a significant amount of resources, introducing ECMO in inexperienced facilities does not guarantee successful outcomes. Even during a pandemic, the Extracorporeal Life Support Organization has issued a statement indicating that ECMO should not be considered the top priority treatment. This is the agenda for this lecture. First of all, VV ECMO is usually indicated for patients with severe respiratory failure based on PF ratio and Mayhall's score in normal cases. PF ratio of 80 or higher is an aggressive indication. Please refer to this table. In the current COVID-19 pandemic, there are many patients who experience severe hypoxemia despite having normal compliance. This condition is referred to as the L type, and is characterized by low elastance, low VQ ventilation perfusion, and low lung weight. As the disease progresses, it transitions to a state similar to the typical ARDS, known as the H type. However, in COVID-19, this transition is said to occur very rapidly, making it crucial not to overlook this point. Therefore, in COVID-19 cases, ECMO is considered for intervention when the PF ratio is around 100 as a guideline. If ECMO is introduced before lung damage occurs in the early stages of L-type and COVID infection, the lungs can be given a rest, preventing unnecessary lung fibrosis and enabling early weaning from ECMO. Although there are measures that can be taken, such as the use of muscle relaxants to eliminate spontaneous breathing, the risk of lung injury is actually increased by the mere presence of an alveolar field with different compliance. Because the strong shear stress between alveoli with different compliance creates strong negative pressure on the alveoli and pulmonary vessels, this repeatedly leads to pulmonary edema, in which water seeps into the interstitium. This can lead to situations such as so-called P-Cili. Therefore, it is important to set the lung rest setting without fail, rather than introducing it early for peace of mind. One hospital in Japan manages such ventilation conditions, leaving oxygenation to VV ECMO. The first step in other management is coagulation control. Because ECMO is a long-term extracorporeal circulation, bleeding and thrombosis prevention is performed simultaneously. Anticoagulation therapy using heparin and other drugs is used, but complications are still frequent, occurring in 50% of COVID-19 patients. At the same time, coagulation abnormalities such as DIC occur, making it difficult to control. ACT and APTT are used for these controls, but both involve blood sampling, which requires going to the bedside, and it is necessary to decide in advance when and how often to perform them to avoid the risk of infection. Prevention of thrombosis in the ECMO circuit is extremely important. Because extracorporeal circulation cannot be performed if thrombosis occurs in the ECMO circuit. In VV, 3 or more monitors are recommended, and by monitoring over time, it is possible to estimate the location of the thrombus in the pump, artificial lung, or other parts of the body. As for circulation, unlike circulating ECMO, it is patient-dependent and must be controlled with inotropic drugs and fluid balance. Infection other than COVID-19 is often overlooked. During ECMO, temperature is controlled in a cold water bath, so findings suggestive of infection, such as temperature changes, tachycardia, and tachypnea, do not become apparent. Due to the possibility of oversight, careful observation, including monitoring for redness at the cannula insertion site, is necessary. The key to VV ECMO is oxygenation by artificial lungs, and as explained earlier, the temperature difference between the air and the gas causes condensation in the lungs, which lowers the gas exchange capacity. In addition to this, there is also a decrease in gas exchange capacity due to plasma leakage, which was mentioned as a topic in this issue of COVID. When a plasma leak occurs, COVID was reportedly detected in the plasma components around the artificial lung. As shown in this case report from a Japanese clinical team, SWEPGAs flows at a rate of about 4 to 5 liters per minute, so it is aerosolized in a ready manner. The gas and condensation were negative, but it is thought that they may have been affected as well. When a plasma leak or trouble occurs up to this point, the circuit must be replaced. The patient's complete dependence on ECMO must be quickly prepared and exchanged within a minute, so it must be simulated in advance. We must also reduce the risk of infection for medical personnel. When we, as medical personnel, are at the bedside of a COVID-19 patient, we wear full PPE like this one to prevent the risk of carrying the virus on our bodies. On the other hand, it is difficult to protect medical equipment brought in from infection in the same way. Even in the literature issued in the early stages of COVID-19 infection, it was clear that the virus could be detected on walls, floors and electronic medical records in hospital rooms, especially on the floor, where the positivity rate was very high and the closer the equipment was to the floor, the more contaminated it was. The ECMO equipment brings not only the main unit but also several other devices such as a cold water tank to heat the blood and a blender to supply oxygen gas. In addition, there are many calibration parts such as cords used with sensors for monitoring. After these items have been used, they must be used safely for the next patient. It is a very labor-intensive task to manually wipe every single one of these items after use to ensure that they are safe for use on the next patient. Finally, there are ethical aspects. ECMO is indicated in the most severe cases, and patients cannot be weaned off ECMO unless there is a chance of recovery from the underlying disease. Therefore, recovery is not good in cases where there is a history of COVID-19 as well as other medical conditions, which is a limitation of ECMO treatment. Under such circumstances, the question is how far to continue the treatment even if it is life-sustaining. Especially during periods of infection spread, ECMO treatment requires many resources, including medical personnel, space, and medical supplies, and even a single person on ECMO can be a significant burden to the hospital. The ELSO guidance recommends that if recovery is not expected after 21 days of ECMO, the patient should be weaned off ECMO and switched to ventilation-only treatment. However, it is a basic principle that any such ethical decision should be based not only on medical indications but also on the patient's own wishes. However, in reality, the patient is put to sleep by anesthesia during ECMO treatment, so it is not possible to confirm the patient's will. Usually, the decision to stop the ECMO treatment is not confirmed. Although it is possible to confirm the patient's decision to do or not to do ECMO prior to the start of the treatment. In such situations, who should hold the decision-making authority among the physician, patient, and family becomes a significant challenge. Can we accept the same decision even in an emergency? It is a big issue. In particular, many people in the COVID-19 treatment were living their daily lives, thinking that they were fine, and therefore had difficulty coping with the environmental and psychological changes when faced with sudden death. When ECMO and ventilators are treated as if they are the most powerful treatment, many people may think that they should do whatever it takes. However, they are often blind to the many resources and money involved, and the risk of long periods of rehabilitation and bedriddenness even after recovery. We as healthcare providers need to share as much information about ECMO treatment with patients and their families as possible, as biased information on TV and news can confuse surrogate decision makers. This is an overview of ECMO treatment.